Get Christy out of the bathroom.
Calm down, or I will escort you
Well,
out.
you're making a scene. I'm so sorry about all of this.
Daughter, lock yourself in. Sister started fighting. Colin's got in the middle. Mom pushed her.
How can I help?
I just want to take my daughter home.
Okay, we will get Christy out and we will bring her to you.
Let us help you.
Right this way.
Okay.
This is your patient?
Yes.
No, actually, it's my patient. She's been here for hours. Patients come in already in distress, and waiting only makes it worse.
Wait time has nothing to do with
Which
this.
is why we're seeing hospital workers like Dr. Collins get assaulted,
Assaulted?
It was a little push.
which we're going to take seriously. We risk our lives coming to work here every day. What if that mother had brought a weapon?
We have metal detectors.
Isn't the hospital full of metal things that can be used as stabbing devices? You got to be really careful here. And what he's saying is absolutely true. Healthcare workers getting abused has become so normalized that it's not even reported at times. And as a result, it's seen as no big deal or just part of the job, when it should absolutely not be that way, should be discouraged by creating mandatory sentencing for individuals who assault healthcare workers, just like you do with other public space employees.
Terrence, I'm Dr. Langdon. Do you go by Terrence or Terry?
Terrence,
So, what brings you in today?
I averted my ankle playing table tennis.
Averted.
Yes.
You mind if I take a look?
Are you an orthopedic surgeon?
No, I am an emergency medicine specialist.
I can't tell if he said everted or inverted. You could have an inversion injury where the outside of your ankle gets its ligament stretched out, potentially torn, or you can have an eversion injury, which is rarer, but if it's severe enough, you could actually tear the deltoid ligament, and the deltoid ligament is so strong that at times it ends up creating an avulsion fracture, tearing a piece of the bone off. So the mechanism of injury here is really important. Did it happen because he jumped off of a 20-foot wall, or did it happen because he missed one step? All will greatly change management. And we do have something known as the Ottawa Protocol that we use to decide whether or not we should get an x-ray for an ankle sprain. This is a very valuable tool to decrease the rate of unnecessary imaging.
Could I talk to an orthopedic surgeon? I'd prefer an expert in that area.
Well, I'm pretty good at ankle sprains.
How do you know it's a sprain?
Well, I'd have to examine you first, but
Could it be a Jones fracture or a dancer's fracture?
could be. Again, I'd have to look. Why don't I examine you, and that'll tell me...
Shouldn't you take a complete history on the present illness first?
Sounds like you're more interested in asking the questions, so...
You didn't ask if I felt the pop or a snap. You didn't ask about previous injuries. You didn't ask about weight bearing.
Why don't I get you some fresh ice?
I think asking, offering what you can do now and then asking the patient what they'd like to have happen within the options that you're giving them will create a healthier line of communication, but taking space is also great. This happens quite often. Again, you're getting people that you don't know, you don't have an established relationship with. There's no continuity of care like you might have in primary care as a family medicine doctor.
Is everything okay, Dr. Langdon?
Yeah, we got Dr. Google in Central 9 bombarding me with questions like my 4-year-old. I couldn't even get through a history.
Yeah, it's easy to get frustrated when a patient comes in asking hyper-specific questions, not allowing you to complete the visit. But I like when patients use Google. Now it's funny, Dr. Google is no longer relevant. I feel like it's Dr. AI. Now patients are using ChatGPT or Gemini or Grok to ask it medical questions. Usually that makes it a little bit more pointed because those things don't just spit out information. They sometimes will ask follow-up questions before giving the information. And in general, it allows me to better understand what my patient is thinking is going on. So if my patient is worried about a fracture and I can reassure him off the exam or the history of present illness that I don't think it's a fracture, that might make the visit go a lot smoother than if I just say, oh, it's just a sprain, no big deal, bye. So use it as a way to facilitate conversation as opposed to a conversation blocker.
Is that his chart?
Yep.
Can I see it?
Knock yourself out.
Is she gonna find that this patient perhaps is neurodivergent?
Oh, he's autistic. Did you see that in his past medical history?
It's an ankle sprain. It has nothing to do with the injury.
It has a lot to do with doctor-patient communication, though, as well as patient satisfaction, patient trust, and all those factors play a role in the outcome. Because it's not just making the right diagnosis and giving the right treatment, which could also get impacted if you don't have good communication. It's also about the outcome.
I could talk to him.
Great. I can see 3 other patients while you do.
Hi, Terrence. I'm Dr. King.
How long?
Dr. Langdon is with another patient right now, so
She's closing the door to decrease the amount of sound coming into the room because that can be a trigger for those who are on the spectrum. So ASD, autism spectrum disorder, happens in a wide variety of presentations of signs and symptoms. So the way one person experiences may not be how another does. But one of the well-known symptoms is an acute distraction, discomfort with loud noise. So by closing the door, she's already taking a good proactive step to improving the conversation.
it's a little bright in here. Oh, that's...
You want to decrease stimulus, or stimuli in this case, because that makes the patient feel more comfortable. I also do this for patients who are experiencing a migraine, because sometimes light sensitivity can be brutal for someone experiencing an acute migraine. There's actually a condition known as status migrainosus, where it's just nonstop, painful migraine, days at a time, sometimes not responsive at all to medications, intractable. So doing things like decreasing noise, decreasing light, moving them to a calmer room does help a lot.
What is your biggest concern today, Terrence? What worries you the most about your the pain in your ankle
What worries me? Do you mean right now in this moment?
right now?
I'm worried I won't be able to play table tennis if it's a bad injury.
Perfect setup. Always teach my residents to do the exact same thing. Ask what is the biggest concern for the patient, or ask what the patient thinks is going on. They're largely the same question phrased in two different approaches, because now you can guide the conversation surrounding what the patient's concern is as opposed to what your concern is. Granted, if you're in the midst of a true emergency, someone's bleeding out, someone's having a stroke, heart attack, there's less of an emphasis on the concern about the patient. There's more of a emphasis on making sure you solve this emergency in the given moment. But here, there's time. You have the time to talk about it.
So Terrence, would you walk around the room for me, please? I'll be able to tell a lot more about your injury.
The fact that he's able to bear weight is good. Part of the Ottawa protocol that I discussed earlier is making sure you're able to bear weight immediately after the injury. So not exactly what's happening here, but also good nonetheless.
Hurts a little.
How painful? On a scale from 1 to 10, 10's the worst.
The worst? The worst I've ever felt, or the worst that a human being can experience?
A little pain is a great answer, Terrence. Thank you. Well, based on your walking around, I don't think it's a serious injury.
As much as I want to say that's a great way to do it, it's not. You do have to do some investigation. You need to be able to see if there's ligamentous laxity, if there's something torn. It's not unusual for someone to have not a ton of pain and then still have a tear. You could also have tears of even the fifth metatarsal, which is on the side of your foot, almost not related to your ankle, because the pain could be on the foot as opposed to the ankle. You need to do a physical exam here. It's not enough to just see someone walk around.
Sometimes this tendon called peroneus brevis can pull off a piece of this bone, the fifth metatarsal.
So we just talked about that, and in a situation where you're having an avulsion fracture at the fifth metatarsal, at the base of the fifth metatarsal, you'd want to be able to palpate the area, meaning touch the region, to make sure that they're having pain there. Because if there's no tenderness there, odds of injury being there is quite low.
That's the dancer's fracture, right?
Exactly. You most likely have a second-degree ankle sprain. The x-ray will tell us everything. Tech will come get you, and then I'll come back and show you the images.
Great.
Okay. I'll put the orders in.
How'd you do that?
Do what?
Talk to another human?
Talk to him.
I listened.
Funny. No, you unlocked something. I wasn't getting anywhere with them.
Oh, my sister is on the spectrum, and the ER can be a very, very overwhelming place for autistic people. So I don't know, it just takes a different approach.
You and your sister close?
Yeah, we're best friends. There's this one time we were on the swing,
I gotta hit the head.
and then
Let me know when the x-rays are back.
Yeah.
And you wonder why you struggle with interpersonal communication.
Mrs. Dunn, how's my dad? He's still stable. His chest tube output is slowed down, which is an excellent sign.
So when we put a chest tube in and it starts draining, as that drainage slows down, that signals to us that healing is taking place and that the injury is becoming smaller, reassuring that the patient is improving.
Mrs. Dunn, can we talk for a moment? Excuse me. We found something in your husband's exam. He has some breast enlargement. Is that unusual? It depends. One common cause is alcoholism. Is he a drinker? He has a few drinks every night. We'll do liver function blood tests for alcoholism. There's also disorders of the endocrine system, so we can check his hormone levels.
I just don't think it's the right time and place. I think flagging that you've caught this sign/symptom and presenting it to the patient with explicit instructions for follow-up on it, whether you choose to do it with a breast specialist, endocrinologist, family medicine doctor. I think that's really important, because if you get bogged down in the ER and trying to make diagnoses for non-life-threatening conditions, that will ultimately ruin the way that you're triaging patients. Because for every patient that you're spending time diagnosing a non-urgent issue, you're taking away time from someone who has an urgent issue that's like bleeding from the head, as one of these patients who has their head wrapped up.
Go! Can somebody help me, please? We need a wheelchair here. What happened? I was on my way home and I saw her in the road. She was in and out of the intersection yelling at cars and people.
What's her name?
Nandi. She's my roommate.
Did she get hit? Her knees are all scraped up.
No, she tripped while I was pulling her out of traffic.
Does she have a psychiatric condition?
Not that I know of.
Let's get her in bed. You're okay.
This is a good example of AMS, altered mental status. It's good that they have someone that knows her present, because they're able to explicitly identify this is not her usual state. Because sometimes in the ER, if someone just shows up, you don't know if this is the norm for them, or are they acting completely unlike themselves because of a medical condition. That gives a lot of context and can further guide treatment and workup.
Ah! What was that?
Olanzapine, 10 milligrams.
Do you know any of her medical history?
No, we've only known each other for a few months. We're both influencers. We met online. I thought it would be a good idea to live together.
When did she start behaving differently?
About a month ago. She's been up at all hours talking to herself nonstop. I think she's suicidal.
Any drug use?
In a situation like that, you have to rule out drug use. You have to rule out mental illness in the family. Schizophrenia is a presentation that could happen in this age group.
No, I don't think so.
Spotty, Whitaker, see if you can do the exam.
Can you look at the light?
No, what was that?
Okay. Open your mouth.
No, it's not real. Where am I?
How do you even do an exam with a patient like this?
The furniture's changed.
Observe her. Wait for her to look at you or open her mouth and get a quick look. Make sure she moves her arms and legs equally.
This is a strategy I use with patients that are babies. Sometimes the parents are like, how are you going to look in the baby's mouth? Well, when the baby starts screaming because I'm poking around on their belly and they don't like it, I get to look in their mouth.
This is just to monitor your heart.
All right, we might need to wait until after the meds kick in.
Also, probably having 6, 7 people in the room is not comforting to a patient who doesn't know where she is. Usually in a situation like that, they get something known as a 1-to-1, which is basically a patient sitter that sits there and makes sure the patient doesn't harm others or themselves.
Okay, differential diagnosis.
Schizophrenia, first psychotic break. She's in the right age range.
Yeah, what else?
The drugs also common in this age group.
Common in all age groups, what else?
So you got to think about what impacts brain function. You could obviously think about poisoning situations. Hypoxia could cause someone to act in a strange way like this, but usually you'd see neurologic signs outside of altered mental status. There could be infectious causes of this, traumatic causes of this, cancerous causes of this.
Not just recreational drugs, could also be toxicity to medications. Don't jump to conclusions, think big categories and then specifics.
Metabolic, hyper or hyponatremia, calcium, hepatic encephalopathy.
I mean, those are extremes for someone who is otherwise healthy.
Endocrine, hyperthyroid, infectious encephalitis.
Thyroid storm could happen, but you'd usually see pretty clear vital sign changes in a thyroid storm.
Those are all possibilities. Okay, let's work her up medically and see if we can clear.
Chem panel, CBC, TSH and T4, drug screen, and HCG.
Yep, if it's all negative, then admit her to psych.
Something that's important to know about healthcare that I think puts us at a disadvantage on social media, and in general, talking to the public, is that doctors hedge bets. You see, like what we did there, they think about what are the most likely candidates, which is drugs, schizophrenia, other mental health conditions, other substances. And then they went down a list called differential diagnosis. We do this purposefully every single time, every single patient. And some might view that as hedging, as if we don't know enough to make a diagnosis. Well, that's partially true, because in order to learn more about the patient, we need to get a really thorough history, thorough physical exam, thorough blood work, thorough imaging if need be, in order to support our case for a condition. And even then, we might not know for sure. But Instagram influencers, like my good friend Gary Brecka, I say that sarcastically, will say things like, the lack of pink Himalayan sea salt is why you're having headaches. They're largely saying that to sound ultra confident, in which they're wrong in most cases, but also to sell you something, either a book or a supplement or some pink Himalayan sea salt.
She's really upset.
She'll get over it.
Weren't you about the same age when you got pregnant with her?
Yes.
So you know how hard it can be.
It was very hard at the time. But she turned out to be the best thing that has ever happened to me.
And I hope she feels the same way when she's ready, but right now, she's not. For her, the world is ending. If you push her away, she might never come back.
Dr. Collins?
Excuse me.
Code STEMI, trauma 2 now. Code STEMI.
A code STEMI is a ST elevation MI. This is when a patient's having a heart attack and there's a very specific pattern that's elucidated on the EKG where you have the segment, the ST segment, actually go up and you're seeing it across a specific pathway on the EKG, meaning in specific leads, signaling to you potentially what part of the heart is impacted or what potentially artery is impacted and blocked off. It can help better plan for when they go into stent the region, and it can help better plan for the cardiac catheterization lab.
Brought in by a coworker after 10 minutes of substernal chest pain with diaphoresis, anterior STEMI and triage.
So usually in a situation like this, you're checking tropes, to see if those muscle proteins from the heart are being leaked out. You're going to be doing those every few hours to trend them, and you're contacting the cath lab to get ready for this patient. And remember, door to balloon time, less than 90 minutes. You want to be moving quick.
You're having a heart attack, sir.
I figured.
You ever had one before? How much pain?
Like an outlet's on my chest. Are you taking any medications? Metformin.
Metformin is one of the classic medications used for diabetes.
And rosuvastatin.
That's a medication used to control cholesterol.
324 chewable aspirin sublingual nitro Q5 × 3.
They're giving him a dilator. They're giving him aspirin, which is to prevent his platelets from clotting and keeping the area as open as possible to minimize the blockage.
Is there anybody we can call?
Oh, my wife died a year ago. I guess today's the day I'll be joining her.
Oh, I appreciate that sentiment, but that is not part of our plan.
No murmurs, radio pulses are symmetric.
How could he have known there's no murmurs? He didn't even put the stethoscope to his chest. He said no murmurs, right? Questionable, sir.
VFib. Whitaker, chest compressions. Charge you 200.
Chest compressions, chest compressions, chest compressions. Unstable rhythm.
Best way to face your
I
fears.
can think of better ways.
Let's back him on 100%.
Again, I would like to see him going a little deeper, at least 2 inches deep into the chest, pushing hard and fast.
Still VFib. Resume compressions. Let's get him on the Lucas.
So the Lucas is this new device that they're using. I've never used it before, that can apparently perform chest compressions more readily than a human can because it doesn't get tired.
No pulse. Clear?
Clear.
That's your cue, Whitaker.
Shit.
No change. Epi and amio, please.
He's not coming back, is he?
We still got a ways to go.
One of Epi's in?
Double sequential defibrillation next.
Worth a shot. I'll put in an art line.
Right sternal border, apex.
The theory is that the first shock lowers the defib threshold, so that the second shock has a better chance of converting into fibrillating myocytes.
So basically he's in an unstable rhythm. So by shocking his heart out of this rhythm, ideally you can restart the normal rhythm in order for the heart to start becoming functional again. And you're doing that not just with the shock, but also with the medication that you're giving, as well as buying time by performing chest compressions.
All right, Whitaker, if he's pulseless, we clear and then shock. I go first, you hit it as fast as you can.
I got it.
Charging both to 200.
Charged.
Pause compressions. No pulse on the A line. Clear for the 1-2 punch.
Clear.
Resuming compressions. That was our Hail Mary.
We got one more. Activate ECMO.
ECMO basically functions as a heart outside of the body. And this is a very mechanical way of helping a person buy time. So very difficult decision to be made in a situation like that.
This is all my fault. What is? Is there something you haven't told us?
Uh-oh.
Mrs. Dunn, in order to effectively treat your husband, we need to know anything that
The hormone levels. It could be the progesterone.
he's taking progesterone?
I've been giving it to him. I put it in his coffee every morning.
What?
I thought if I could kill his libido, we'd stop.
Stop what?
I think he's our daughter.
Oh my God. What?
You've been here about 7 hours. Hit your head and came in unconscious. Took a pretty nasty fall.
The tea?
Yeah, on the T-tracks.
What about the Asian lady? How's she doing?
Minu. She's doing a lot better.
Did the cops catch the guy who pushed her?
She was pushed.
Yeah, I saw it.
The fact that he has this much memory is very reassuring.
Nandi, why did you wander into traffic today?
I was afraid of people coming after me. I don't feel safe at home.
Who's coming after you?
I don't know. Something changed.
When?
Maybe a month ago. I was worried all the time. Trouble sleeping.
What about physical symptoms? Pain, aches?
My hands shake.
Could be some rare neurologic condition, or it could be something as simple as thyroid still.
My feet get numb.
Peripheral neuropathy.
What else?
I don't recognize myself in the mirror sometimes. I feel like I'm in a dream and nothing is real.
Any ideas? Call for a psych consult? Let's ask for a head CT with contrast first. Looking for what? Tremors, coordination problems? Frontal lobe lesions can cause behavioral changes.
Yeah, that's what I was thinking, but it's a Hail Mary for someone of that age, but worth checking. I mean, altered mental status to this degree should be worked up fully.
Robbie.
Here we go. ABG.
Looks good.
ABG is an arterial blood gas. It basically shows you the oxygenation level, acid base level of the blood.
I'll get a garden hose coming out of the vein at the right leg that flows into the ECMO machine for oxygen and gets pumped back through a second hose into the left femoral artery.
These guys are impressive.
That's basically the catheters that they put into the blood vessels in order to be able to put, using the guide wire, place the catheter across the guide wire and place it into the location that is deemed necessary.
Dr. Robbie?
Yep.
Can we talk about the patient in Trauma 1, Silas, the fixer-upper who fell off the ladder?
Are his labs back yet?
No, but his wife, Susan, told me that she's been putting progesterone in his coffee.
Progesterone? Why?
She wanted to kill his sex drive. He's been f***ing their daughter.
We don't know that.
What exactly did the wife say?
He goes into the kid's bathroom when she's showering, gives her unwanted massages. Her behavior's changed. She's struggling in school. The mom is really worried.
But she hasn't talked to her daughter about any of this, doesn't want to put ideas in her head.
It's grooming. And we are mandated reporters of child abuse in Pennsylvania.
Yeah, you're mandated to report if you know it's happening for sure, and there's a strong suspicion that you should investigate. But reporting and investigating, there's a little bit of a line there.
There's nothing to report unless we have proof. Right now, it's all speculative.
Are we obligated to report mom for poisoning the husband?
Unfortunately, yes.
She's not trying to kill him. She's just worried about her daughter.
He fell off a ladder. He broke a bunch of ribs. You're the one who's treating him. What if next time it's worse?
So we're just gonna send her home and wait till she comes back as a victim of incest?
We can't do anything unless the daughter comes forward. We can try to talk to her, but if mom doesn't want us to.
I will talk to the mom.
Yeah, I mean, I wouldn't write this off as aggressively as they are. I think it's definitely worth a continued investigation. And perhaps it will ultimately get reported. It just, you don't rush to report it because, first of all, he's intubated. And you need to figure out the facts in order to present the facts.
First line's and clamped. The two catheters have to get attached to the ECMO lines with no air bubbles. You see what's happening?
Good to go.
Circuit on.
And clamping.
Okay, it's venous blood out the right femoral into ECMO for oxygen, then pump back into the left femoral artery.
And obviously this is, again, to buy time, temporary solution.
What's the map?
74.
Excellent.
That's the mean arterial pressure, basically the pressure within the arterial system.
So the ECMO is taking over for the heart and lungs. Once they open up the blocked artery, they can restart the heart. It's basically good as new.
Well, not exactly good as new because the area of the heart is still experiencing a blockage and therefore dying. So you want to try and open up that area as quickly as possible.
Are you and your dad close?
Yeah.
Has your dad ever made you feel uncomfortable?
What do you mean?
Has he ever done anything to you that didn't feel right? It may seem harmless for him to go into the bathroom when you're taking a shower, but it's not.
Where is this coming from?
You got to be careful with stuff like this. In a hallway in front of other people.
I need to find my mom.
Alana, wait.
He's literally talking to the mom, finding out how they're going to have this conversation. And you started that. And you stabbed one of your colleagues. This is a bad shift.
She's been cleared for psych, but she keeps saying something's wrong. It doesn't feel right to me.
Listen to your patient. That is your superpower.
But Robbie told me to move on. I finally got on his good side.
Robbie's off today. Trust your gut. I'll back you up.
What does she want her to do?
Well, there's no fracture, so it is just a sprain. Sprains usually take about 6 weeks to fully heal.
I love the brace that she's using. That's like my favorite brace when you have protection on both sides to allow you to keep this motion, but to decrease the eversion and inversion. Because what happens is if you tie it up too tight, sometimes people use these really strong braces. You could decrease movement in the ankle so strongly to the point where it takes longer to rehab than necessary. What I like with ankle sprain injuries is to mobilize early, and I'm talking gentle mobilization, like doing the alphabet with your big toe, just doing some pedal presses in the air or while you're sitting down. That sort of mobilization decreases length of recovery. And I know this not just from treating a lot of patients with this, but also experiencing a lot of ankle sprains. Look at my ankle.
Weight bearing has actually been shown to speed up the healing process.
One of the mnemonics we use in medical school for the main ligament that is frequently torn is called the anterior talofibular ligament, ATF. And the joke that we used to say is it's always torn first because it's in this one susceptible area that if you get an inversion injury, that's the ligament that gets torn very commonly. I actually don't have an ATF ligament anymore. So my ankle is a lot more loose than your traditional ankle. So you can live with it, but your risk of re-injury is very high. So I encourage a lot of my patients, even when they don't have a full tear, to do physical therapy and rehab their ankle well, because when you have one ankle injury, it really does predispose you to more ankle injuries, which can spur all sorts of problems, issues with the bone, walking, etc. And a big part of it is knowing where you are in space, the joint proprioception, which is knowledge of where that joint is. So frequently, you could tell if you've had injuries on one ankle versus another just by standing on that one side and seeing if you have good balance with your eyes closed.
Your labs and your brain scan are all normal.
So then what's wrong with me?
We're having a psychiatrist come talk with you.
You think I'm crazy?
A psychiatric illness could just be
I'm
causing
not
your
crazy.
symptoms.
You have to believe me.
Please.
Well, I don't understand what she's looking at her fingernails.
Take me through your skincare routine. Don't leave anything out. Write this down.
I thought psych was taking over.
I haven't called them yet.
Got 5 patients back here that haven't been seen yet. 51 more in the waiting room.
I'm thinking this is a toxicology case.
Everything is pointing to new onset schizophrenia. So what zebra are you hunting?
She's been using a face cream from Asia with a high mercury content. This could explain all her symptoms. Look, the FDA website has a list of imported products that contain mercury. She's been using this one. I've ordered a heavy metal panel looking for mercury, lead, or arsenic.
Why didn't you consult me?
I consulted Dr. Collins.
Dr. Collins is not supervising this case.
I know. I just didn't know if...
If what?
I thought you were having a bad day.
Did Dr. Collins say that?
No, she was just trying to help.
Don't ever do that again. Did you sign off on a heavy metals panel on new onset psychosis?
What?
Samira's patient. I cleared her for psych. You overrode me?
If Samira put it in order, there was a reason.
Her choice to do that was driven by data and a true analysis. So I don't understand how one can get mad at that. There is exposure. There is a mechanism. So you order the screen and you see what's going on.
Right.
Okay, so your husband is going to be admitted to the ICU, and if everything goes well, then we'll extubate him and the chest tube can come out. But he's going to need to stay in the hospital for 3 or 4 days.
Thank you. I'm gonna take Alana home, but I'll be back later.
There's one other thing. Dr. Santos filled us in on your conversation. What you did to your husband is against the law. So unfortunately, we're required to report it to the police.
Police? I wasn't trying to hurt him.
Even so, this is where he ended up. I would suggest that you speak to somebody about your feelings and talk to your daughter. If there is something happening at home, she'll need to know that you're willing to listen.
We have resources I can provide, which include connecting you to the authorities.
We'll be fine.
Isn't she gonna get arrested right now?
Wait out here.
Okay.
Is she gonna question him?
There he is. Remember me? So I talked to your wife and daughter about your extracurricular activities. Yeah, it didn't say in your chart that you were a child.
Oh my God!
Yeah.
He's just undergone a major injury. He's hypoxic. You don't know what his mental state is.
You are never going to touch your daughter again. You are never going to look at her or even think about her inappropriately. Or Officer Ahmad out there is going to arrest you. Blink twice if you agree to this. Once if you want me to let you die. I've already lost 2 patients today. One more's not going to make a difference.
That is not your place as a physician. And we don't even know if this is true.
Mifepristone.
You sure you want to do this?
Yes.
Well, I'm glad they were able to do this as a family. That's amazing counseling. The fact that the ER helped them come to a peaceful decision is really impressive.
Good luck to both of you.
That's a thankless job of healthcare. You did something really good. You connected the family to make this decision. You educated. No, thank you. Uh-oh. Vomiting? What's happening? Did she have a miscarriage? This episode featured an influencer who used the viral health trend. Well, here are some of the dangers of the most viral health trends here. Click here, check that out, and as always, stay happy and healthy.